Peace and light. My name is Dr. Sonia Fulgham, a clinical psychologist with a master's in pharmacology, and I welcome you to this presentation where we will be gaining an understanding on how to identify and treat childhood bipolar disorder. Oftentimes, our children get excited about a new idea and begin focusing their energy on pursuing it. And this is perfectly healthy. However, when the idea is excessively grand and becomes the only thing worth their energy and time, this can become a bit worrisome and may need psychiatric attention. To help us put the identification and treatment of childhood bipolar disorder in context, here is a case vignette that shall form the basis of our presentation. A 14-year-old adolescent boy is brought into the ER after being found in the basement of his home by his parents during the middle of a school day. The parents came home after receiving a call from the school reporting that their son had not attended school for 4 days. The boy was furiously working on a project he claimed would solve the fuel crisis. He had started returning home from school after his parents left for work because his science teacher would no longer let him use the school lab after hours. The patient was involved in an altercation with the school janitor after being asked to leave the school because it was so late. The boy claimed that the janitor was a foreign spy trying to stop his progress. The parents are very proud of their son's interest in science, however, admits that he has been more difficult to manage lately. He can't stop talking about this project, and others cannot get a word in edgewise. His enthusiasm is now palpable. For the past few weeks, he reads late into the night and gets minimal amounts of sleep. Despite this, he seems to have plenty of energy and amazes his parents and friends with detailed plans on how he is going to save the world. His friends have not been able to tolerate his increased interest in his project. His train of thought is difficult to follow. He's pacing around the examination room saying, "I am anxious to get back to my project before it's too late." And although he has no suspects in mind, he is concerned that his life may be in danger because of the importance of his work. Now let's take a look at the diagnostic criteria. On this slide, we should be taking a look at the DSM-5's diagnostic criteria for childhood bipolar in connection with our patient as presented in the previous slide in order to see how his behavior compares. The first DSM criterion is experiencing distinctive periods of persistently and abnormally elevated behavioral mannerisms, such as persistently goal-directed energy or behavior coupled with irritability and lasting for 1 week or more, with the presence most of the day on nearly a daily basis. Consistent with the criterion, our patient has been persistently and abnormally focusing on the goal of solving the present fuel crisis and directing all of his energy to this goal daily for more than 1 week now. The DSM-5 criterion also indicates that during the mood disturbance period, the individual demonstrates at least 3 of the following symptoms, with notable changes from usual behavior. 1 being inflated grandiosity or self-esteem. 2, decreased need for sleep. 3, being abnormally talkative or feeling pressured to keep talking. 4, flight of ideas of subjective experiences that thoughts are racing. 5, distractibility, which is defined as attention being too easily drawn to irrelevant or unimportant external stimuli as observed or reported. Excessive involvement in pleasurable activities with high potential for painful repercussions like foolish business investments, shopping sprees, sexual indiscretions, and so on. Our patient checks the following 5 symptoms. He demonstrates notable decrease in the need for sleep. He also can't seem to stop talking about his project, and others can't get a word in edgewise. He has a difficult to follow train of thought. He is also too focused on his goals of solving the fuel crisis and is missing out on important aspects of his life, as demonstrated in him skipping school. Sufficiently severe mood disturbance to inflict notable impairment in occupation or social functioning or warranted hospitalization. The patient has had mood disturbances that have resulted in him skipping school because of him being angry at the teacher that would not allow him to use the lab for his project. The episode is not because of a medical condition or the direct physiological effects of a substance like medication, treatment, or drug abuse. The patient in our case does not have a history of taking any substances or any underlying medical conditions that could explain his unusual persistent behavior. So we're going to take a look at differential diagnosis. It is possible for bipolar disorder to be diagnosed as another disorder, partially because of the heterogeneity of the clinical presentation of bipolar disorder. Examples of the condition with such heterogeneity of symptoms include major depressive disorder, psychothymic disorder, schizophrenia, psychoaffective disorder, attention deficit hyperactivity disorder, substance and medication use, including withdrawal symptoms, and mania caused by general medical conditions and infections. So, to minimize the chances of conducting incorrect diagnosis, it is important to conduct a systematic interview to assess all DSM-5 criteria based on functional impairment and duration criteria for bipolar disorder. You should need to be aware of both the DSM-5 mood criteria in terms of expansiveness, irritability, and elevation, and the related criteria for hypomanic and manic episodes included grandiosity, indiscretion, and distractibility. You also have to consider the suitability of symptoms in terms of particular demographics. For instance, the onset of new manic symptoms for a 50-year-old is comparatively rare and could imply an underlying neurological or medical condition. Adopt a longitudinal history perspective, such as evidence of prepubescent depression. Consider common comorbid conditions and particularly anxiety, substance, and alcohol use disorders, as opposed to individual symptoms. It is advisable to assess symptom constellations. And, for instance, it would be important in this case of the patient referred into this study to determine whether his decreased need for sleep accompanies periods of increased explosive behavior or irritability. Now let's take a look at the FDA-approved treatments. There are several FDA-approved medications for treatment of bipolar in adolescents and children. They include lithium for children aged 12 and above, acenapin aripiprazole, quetiapine, risperidone, fluoxetine, and lorazepam. Notably, most of the medications that are approved are used for treating adult bipolar disorders are also used in children and adolescents. For illustration purposes of the presentation, let's focus our attention on lithium, lorazepam, and fluoxetine for illustration purposes. Lithium is the most preferred drug for treating adult bipolar disorder. Its mechanisms of actions entail acute stimulation of the NMDA receptor, which results in increased glutamate availability with the postsynaptic neuron. The side effects of lithium include headaches, nausea, appetite changes, dry mouth, dizziness, drowsiness, hand tremors, and diarrhea. Lorazepam is a full antagonist at dopamine D2 receptor, and both serotonin 5-HT7 and 5-HT2A receptors, with the highest binding affinity for the 5-HT7 receptors compared to other atypical antipsychotics. It is also partial antagonist of serotonin 5-HT1A receptor. Now, although it has a safety advantage over other atypical antipsychotics agents, the most common side effects associated with lorazepam in patients with bipolar disorder are nausea, headache, akathisia, sedation, and extrapyramidal. Fluoxetine's mechanism of action entail blocking serotonin reuptake into the presynaptic serotonin neurons by blocking the reuptake transporter protein, which is situated within the presynaptic terminal. Fluoxetine also has mild activity at the 5-HT2C and 5-HT2A receptors. And with fluoxetine, the common side effects include nausea, headaches, weakness, and fatigue, diarrhea, and problems with sleeping. Okay, so here are the off-label treatments. Some medications are approved for treating other conditions and not for bipolar disorder in children and adolescents. However, their benefits in treating symptoms similar to those of bipolar disorder may lead to psychiatrists prescribing them an off-label treatment intervention. Examples of off-label drugs that are used in treating bipolar disorder in children and adults include gabapentin, which works by acting on the calcium channel and is approved for treatment of postherpetic neuralgia and partial seizures. And it could cause drowsiness, coordination loss, dizziness, tremors, unusual eye movements, and double blurred vision. Carbamazepine is a sodium channel antagonist approved for bipolar 1 disorder and whose side effects include nausea, drowsiness, dizziness, dry mouth, and loss of steadiness, coordination, or balance. The valproic sodium, whose mechanism of action entails voltage sensitivity to sodium channels, is approved for adult bipolar 1 disorder as well and could cause diarrhea, drowsiness, dizziness, tremors, double or blurred vision, and unsteadiness. Lamotrigine is an anticonvulsant with FDA approval for treating bipolar 1 disorders in adults, and that works by blocking sodium channels and inhibiting the release of glutamate. It could cause similar side effects as the valproic sodium. Now let's explore diagnosis and pharmacological controversies. Despite the growing prevalence of childhood bipolar disorder controversies that loom over diagnosis and pharmacological treatment of bipolar disorder, the following are the origin of these diagnostic and pharmacological controversies. The confusion between ADHD related mania and bipolar disorder is not uncommon in children and young adolescents. This is especially because naturally children with ADHD tend to have low tolerance level for frustration, which equates to mood dysregulation or irritability in the DSM 5 criteria for bipolar disorder. Thus, a child or adolescent with ADHD might as well be misdiagnosed as having bipolar disorder and receive the wrong pharmacological intervention. Now, with respect to irritability itself, it is not properly defined, especially for children, which means that irritable ADHD mood symptoms in children could easily be classified as mixed episodes. Distinctive episodes for mania are also poorly defined, which has led to increased emphasis on symptoms as basis for diagnosis. For example, defining symptoms by duration of at least a week does not include an offset of symptoms leading to manic episodes lasting years in children. There has also been a shortfall in terms of approach for managing information from multiple informants. Diagnosis in child psychiatry varies based on whether the positive symptoms reported by every informant are counted, even when inconsistent with those of other informants, and this could lead to misdiagnosis. Interviews, whether semi structured or structured, collect different information that inform the diagnosis, has the tendency to equate them, often leads to misdiagnosis or underdiagnosis since each interview collects different information from one another. Now, there are also challenges of double counting the symptoms where an individual ends up meeting the criteria for bipolar disorder and another disorder based on the same set of symptoms, or the thought that the problem can be avoided simply by overlooking overlapping symptoms. Besides symptom duration, neurobiology, and mood state frequency, the constellation of comorbid symptoms, the accompanied bipolar disorder render differential diagnosis difficult, especially when symptoms overlap. There is also the question of suitability of using adult bipolar disorder medication in treating childhood bipolar disorder, even at smaller quantities, despite the FDA approval of the likes of lithium for treatment of adult bipolar disorder. Now, before ending this presentation, here are some key points to walk away with. The diagnosis and treatment of childhood bipolar disorder requires keen assessment to establish proper diagnosis based on the DSM 5 criteria. Some conditions like ADHD have similar symptomatic traits as bipolar disorder, and this makes differential diagnosis difficult. It is also noteworthy that most of the medications that are approved for treatment of adult bipolar are also used in treating childhood bipolar disorder, both on and off label. And now, even with the significant strides made towards the diagnosis and treatment of childhood bipolar disorder, heated debates and controversy in this regards are still ongoing and could continue in the future. And there we have it. Peace and light, my friends. We have come to the end of this presentation, and it's now time for an open forum where your comments and questions are welcome. Thank you for your audience and have an amazing day on purpose. Peace.